Thank you, Maddie. Good afternoon, everyone. It's a great honor to be here to present my presentation. Also, thank you for inviting me. I really appreciate. Congratulations for great success. Today, I'd like to talk about this. Before talking about topic, let me just share my complication, the perforation or distal embolization. I was trying to advance the guide wire, but failed like this. Okay. Next one, the very heavily calcified lesion. I advanced the guide wire, serial guide wire, but failed. The very heavily calcified. It's a good malcolm, but failed. This case is an 86-year-old female. Target is here, very tight stenosis. Initially, valangioplasty was performed like this, but the indentation is remaining here. Therefore, so I use the cutting balloon. However, so you can see the hole like this. The perforation was occurred. Even if you can use the true path, so I advance the true perispinal artery like this, believing the sound guided. However, so true path can make a hole and make a fistula like this. So as you can see, the wire perforation or true path perforation. How should we do managed? So I am thinking the option of the management of perforation which we can do is very limited. So initially, the inflow blockage of inflow. So by using the balloon tamponade. The second, the manual compression or mechanical compression from the outer side for 5 or 10 minutes. Then finally, it failed, so we may should consider the colon embolization. Okay, let's move on to the next topic, the distal embolization. But actually, to be honest, I have few distal embolization in tibial intervention. So we usually encounter the distal embolization during the iliac CDO or fempop CDO. Therefore, so I will show you the case. Instant occlusion. Balloon angioplasty was performed to cover the whole instant occlusion side. The result is pretty nice. However, as you can see, the plaque has been dropping like this. Then I use the aspiration catheter like this. Then we get the plaque like this. However, so to avoid the avoidance of this emboli is also much important. I think initially after the guide wire passage, I used the jet stream for the fresh lumbers of the or flash plaque. After that, the result is not so bad, rather good. Then we can check the lumbers from the cover like this. Then we can find the big lumbers like a worm. Yeah, great. So the next, for the management of the emboli, so we usually use the prostaglandin E1 during the procedure after occurrence of the emboli, or so we are using the nitroprusside or a nitro injection to become a good runoff. Or sometimes, in some cases, we use the anticoagulant drug. So without the acutylene So sometimes we use the aspiration catheter or mechanical thrombectomy, but mechanical thrombectomy is not available in Japan yet. Therefore, it's very limited. That's all. Thank you very much.
Thank you.